First item is introduction for bill introductions. Does anybody have any bill introductions? Seeing none, budget recommendations for the Board of Pharmacies, Board of Mortuary Arts, and the Guardianship Program. Committee, do we have any recommendations for the Board of Pharmacy? Seeing none, could I have a motion to approve the governor's recs for 2022 and 23 for the Board of Pharmacies?
Chairman, I'll move to accept the governor's recs for the Board of Pharmacy for 22 and 23.
Very good. Do I have a second? Second by Representative Lynn. All in favor say aye.
Aye.
Opposed, same sign. Motion carries. Do I have a motion to approve the budget for the Board of Mortuary Arts for 22 and 23 as recommended by the governor? Representative Vaughn.
Thank you, Mr. Chair. I move that we approve the governor's recommendations for the Board of Mortuary Arts budget for years 22 and 23.
Do I have a second? Representative Helmer. Discussion? That's what I forgot the first time. Discussion? Sorry, it's been a year. Seeing none, all in favor say aye.
Aye.
Opposed, same sign. Motion carries. Do I have a motion to approve the guardianship program? Okay. Go ahead and make it for 22 and 23, girl.
I make the motion to approve our guardianship program for 2022 and 2023.
Do I have a second? Second by Representative Howerton. Discussion? Seeing none, all in favor?
Aye.
Aye.
Opposed? Same sign. Motion carries. Very good, committee. That's our first budgets that we approved this year. So the first of 13. So we have 10 to go. So we're in great shape. And I wish that they would all just go along like that, but we all know that's not the case. Okay, first up, Megan, are you going to give us a little overview of the care provider reimbursement rates?
Thank you, Mr. Chairman. I'm not going to take much of your time, but I wanted to call attention. There's posted online with today's testimony is a memo titled care provider reimbursement. It's a memo that KLRD put together that provides some of the big picture context for the testimony that you'll be hearing today. It walks through the funding stream from MCOs to providers and some of the regulations that are around that. I just wanted to point it out. It might be helpful to as you're hearing the testimony today and thinking about it.
Very good. Committee questions. I might add that Megan made this up for me so she didn't have to answer my questions all the time about provider rates. And the first one had involved crayons. So anyway. All right. Well, thank you very much, Megan. Next, Director Fertig is going to give us an explanation of provider rates. Very good. Thank you for being here.
There we go. Now the mic's on. Thank you, Mr. Chairman. Good afternoon, committee. Good to be back in social services budget. So I wanted to share a little bit of information with you all on Medicaid provider rate setting. This has been a topic that has been the subject of a lot of discussion in the last couple of years. As legislators, when you hear from Medicaid providers in your districts, in all likelihood, you're going to hear them asking about the rates that Medicaid reimburses them for. So what we've been doing on the KDHE side is doing some research to try and figure out kind of what rules apply to Medicaid provider rate setting, and kind of some historical information to help guide our discussions today on how to best position the Medicaid program going forward. So I've included a couple slides in our presentation today. The first one is just a little bit of background here. So, you know, and just for a little bit of background for everyone on the committee, I am an attorney by training. So when I try and puzzle out a problem, the first thing I always do is go to what the statutes say. So that's what I've done here in this slide. So in trying to kind of figure out what the requirements are for Medicaid provider rates, I looked into federal law. And so in federal law, it doesn't say you have to pay a certain percentage of Medicare for Medicaid provider rates. Instead, we have kind of a wishy-washy standard that says that we have to pay rates that are sufficient to enlist enough providers so that folks on Medicaid have comparable access to care as folks in the general population. So kind of a general goal rather than a standard. So that's federal law. But under state law, there really isn't any requirement in terms of how we set Medicaid rates. Some states have a requirement that Medicaid has to pay X percent of the going Medicare rate, whether that's 80%, 100%, what have you. We don't have anything like that in Kansas. So there's no statutory standard for how much we pay providers from the Medicaid program. And there's also no statutory requirement that we update those rates periodically. And so what we've discovered is that over the years, rate increases tend to be kind of ad hoc. You might have a provider group come to the legislature and ask for an appropriation to increase their rates. That happens pretty regularly. Or the Medicaid agency, kind of on their own or under direction from the governor, what have you, might decide on their own to request a rate increase through the caseloads process. So there hasn't been a whole lot of uniformity historically in the Kansas Medicaid program for that. So also in our research, we discovered that back in the early 90s, I believe, there was an informal practice established within the Medicaid agency at the time, which was SRS, to set provider rates at 65% of Medicare. So if you're bringing a new service online, that type of thing, you would set the reimbursement rate at 65% of whatever Medicare was at the time. This isn't formalized in policy or regulation anywhere. It's just kind of, the word I like to use is folklore. It's kind of folklore from the state Medicaid agency that is how we would initially set rates. But again, because there's no requirement that we go back and periodically update rates, just because we initially set them at 65 doesn't mean they stay at 65% year after year. So we do have one exception. In the mid-90s, the state Medicaid agency did adopt a formal policy to set laboratory rates at 85% of Medicare. And the concern there, from what I've discovered, is that there's actual material costs associated with labs, and you want to at least reimburse providers for the cost of those materials. So that was the thinking behind the 85% of Medicare threshold for lab rates. And another complicating factor is that there are some services that we cover for which a Medicare rate is not assigned, for instance, dental services. And there are some providers that have their own special rate setting process, federal qualified health centers, nursing facilities. There's some providers that have their own special rate setting processes, so it's not uniform across. And we've also been doing some digging into how long it's been since various Medicaid rates have been increased. And those of you on the Bethel Committee, since these slides were published, we did a little bit more analysis. So sneak preview, you're going to hear more about this on Friday, assuming we're not all snowed out from the State House. But I asked our team to go back and pull of all of the codes we currently cover. When was the last time each of those codes had seen a rate increase? And what I discovered is that we're currently covering over 31,000 individual service codes. So quite a few that we cover under Medicaid now. And this includes different modifiers that might apply to a particular service. And of those, almost 14,000 have received a rate increase since January 1st, 2016. One thing we discovered digging into that a little bit more is that most of those increases were, and those of you who are in the legislature around 2015, 2016, may recall there was a governor's allotment that called for a 4% cut to Medicaid rates in 2016. Most of those rate increases that happened since January 1st, 2016 were reinstating that 4% cut. So they weren't really rate increases, they were more reinstating cuts. And then between 2011 and 2015, there were about 1,400 codes that received a rate increase. So I'm not the best at doing math on my feet, but that tells you that we've got maybe about 15,000 codes that haven't seen a rate increase in over 10 years. And Bethel folks, I'll have more information for you on Friday. I will tell you that I thought briefly about, and I think I told Megan Leopold, I thought briefly about printing out this report that I had our staff pull. I tried to do that this morning, and it was going to be almost 1,500 pages long. And for reference, War and Peace is only 1,200 pages long. So I thought, yeah, that's just cruel. I can't do that to you all, but we do have it if anyone really wishes to see what all those codes look like. It's pretty remarkable. So moving along, so because Medicaid provider rate adjustments, they've really been kind of ad hoc over the years, and there isn't really a formalized process for doing those increases. We have a lot of rates that have basically remained stagnant for over 20 years. One that I highlight on this slide is code 59400 and 59510. I've memorized these codes because I've talked about them so much with my staff, and those are the global obstetric codes. So these are the codes that we pay providers for standard prenatal care, delivering a baby, and then standard postpartum care for the 2 months that the woman is eligible postpartum currently. Those rates have not been increased since November 1994. And I started looking into those in particular after I got a call from an obstetrician out of Hutchinson saying, why have I been paid the same amount to deliver a baby for over 20 years? And so my first thing I thought to do was fact check that, and lo and behold, she was right. So that's one example. Those of you who are on the Bethel Committee back in December, you also heard from EMS providers about ambulance service rates. And we do know that some of our rates are really far below Medicare. For instance, the rural Medicare rate for ambulance services is $11.55 a mile. We pay $3 a mile, so quite a difference between rural Medicaid. And I will add that we only recently started paying $3 a mile. There was a rate increase that went through in 2018. We had been paying $2.50 a mile until we upped it to $3 a mile. Yes, I agree. So how rate increases go through, I provide a little bit of an explanation here of the caseloads process, very, very high level. And so essentially, you know, the agency will kind of look at policies that we might want to push through the caseloads process. And once we vet it internally and pass that out internally, then it goes to the list for discussion during caseloads. And during caseloads, representatives from KDHE, KDADS, DCF, Legislative Research, and the Division of Budget all kind of get together and talk about all of these and kind of vet them, and it's another layer of oversight there. And then once we estimate what the final caseloads estimates are going to be, then they're eventually presented to the legislature for approval. So you'll have a chance to do that in the spring this year. And I would note that the caseloads process doesn't cover all Medicaid rates because some of them fall outside that process. So for instance, home and community-based services waivers that KDADS administers, those require a standalone appropriation. And whenever you hear KDAD's budget, you will hear some of those requests for those rates. And then the last slide provide kind of what our agency priorities are to give you an idea of some of the things that we're kind of debating internally. As I mentioned, there are two codes, the global obstetric codes. We're looking at a very modest increase to those rates. It turns out that our current rates are sitting closer to about 58% of Medicare because they've been stagnant for so long. We would like to move those back up to 65% as a starting point. So a very modest increase. It's turning out to be a little bit more complicated than we think because evidently we have to do a state plan amendment to our Medicaid state plan in order to accomplish this. We don't always have to do that if we're increasing provider rates, but for some reason, for this one we do, and I defer to our experts on that. So there's an administrative hurdle that we have to clear before we can do this. But this is something that I think we'll probably be looking at in caseloads this spring. And then KDADS has a couple supplemental and enhancement requests that are part of their budget. And I believe the governor has approved those. And one of them, again, will not be a surprise to anyone who's on Bethel or served on the IDD waiver committee in the interim. But one of them is to look at increasing the private duty nursing code for the IDD waiver to make it level with a technology assisted waiver. These are both programs for individuals with disabilities that Medicaid pays for, and one of them pays a lot more per hour for private duty nursing than the other. So we're looking to level that, and I believe this committee has discussed that as well. And then the other thing that KDADS is looking at in particular is to increase and level the rate for personal care attendant services across the 4 home and community-based services waivers that offer that service. Right now, it's different across all 4 of those waivers. And so you hear sometimes someone wants to switch from one waiver to another because the rate for personal care attendant services is higher. And we think Medicaid beneficiaries should not have to jump through those hoops to try and get services. So they're looking to increase and level across those waivers. And then we're also studying some other proposals that we've heard. At the December Bob Bethel meeting, we did hear from EMS providers seeking rate increases. They actually submitted a formal proposal to us. And so we vetted that, and we mostly agree with their math. I think our math is slightly different, but we'll be sharing some of that information at the Care Oversight Committee on Friday. We also heard back in the December Care Oversight Committee from pediatricians. They're interested in seeing a rate increase, particularly on the primary care side. So we're doing some analysis there to figure out what that would cost. And then we've also heard lately about mid-level practitioners, such as APRNs and certified nurse midwives. There's a state regulation that has been on the books since 1983 that sets the rate of pay for mid-level practitioners at 75% of the physician rate. So that's why we have it that way. It's been on the books for a very long time, but we are looking to see what it would cost, if we were to try and take what we call it the haircut informally, if we were to take away that 25% haircut for mid-level practitioners. And so, Mr. Chairman, that concludes my kind of high-level overview. If any members have any questions, I'd be happy to stand for them.
Representative Clifford.
Thank you, Mr. Chairman. Do any other states have like an RVS update committee like the RUC that Medicare has? I'm very familiar with that.
I am slightly familiar with that, Representative Clifford. And Mr. Chairman, there are some states who have a much more formalized process for setting Medicaid rates. I think Colorado might be one of them, where they have a formal committee that convenes and sets them. Those are typically states where there's something in law that mandates that rates be updated according to a particular methodology or on a particular schedule. We don't have anything like that.
If I might comment, Mr. Chairman, we have chaos, as far as I'm concerned. It'd be nice to have a formal process for everyone. Thank you. Mr.
Chairman, I don't disagree with that assessment.
I think it's just a matter of how to pay for it. It's that simple. So, Representative Vaughn.
Thank you, Mr. Chair. This is really helpful. Thank you for the presentation. I was wondering, you said the informal policy is 65% of Medicare rates. Do you have the national average reimbursement by chance? Or do you know what some of our surrounding states do? Thank you.
Thank you. And Mr. Chairman, I have asked for that information. Unfortunately, it's not very easy to call. There are some other states, including neighboring states, that have more of an ad hoc approach like we do. I have heard from our clinical team that sometimes when they're on calls with other states, they hear other states complaining that they only pay 75% of Medicare. And, our staff just kind of sits there very quietly because in some cases we're paying much, much less than that. But that is a very good question. And this is a task I will take to my team, see if they can help us answer that.
Thank you. And a quick follow-up, if I may, Mr. Chair. So I'm also on Children and Seniors Committee, and we've heard about And I think maybe you have talked about different ways to determine those reimbursement rates, such as, I don't know if you talked about parity, which I think is possibly having Medicaid the same as Medicare, which I don't have any background on that. But then one was fee for service. Could you talk a little bit about just what those different types of ways to determine the provider rates are, just so I have a little bit more background on that. Thank you. If that's appropriate, Mr. Chair. Thank you.
Mr. Chair, I'm happy to answer that question. So fee for service essentially refers to a Medicaid system where we just pay providers for whatever the service is that an individual receives. It's in contrast to managed care, where you have an MCO. There might be prior authorization requirements for certain services. There's more utilization management, utilization review with managed care. So that's where fee-for-service comes into play. When we talk about payment parity, it kind of depends on the context. We've heard that term a lot in the last year from various committees, and the context might be different. So sometimes you hear about parity, and what they're asking us to do is pay Medicare rates, just pay 100% of Medicare. So sometimes that's what folks are referring to. Other times they might be referring, if we're paying a lower, for instance, with the mid-level practitioners, they might say, well, it's not fair that we're paying 75% of the physician rate if the service is provided by an APRN. It should be 100% across the board. Sometimes that's what they're talking about. It kind of depends on the context, but generally, anytime you talk about parity in Medicaid rates, usually what they're talking about is fairness, what they perceive to be fairness in some way.
That is a very helpful background. Thank you. And thank you, Mr. Chair.
Any further questions? Representative Ballard.
We were just discussing that. Okay, so the codes are set, they're federal, right? Are all codes, the 31,000 you're talking about, are they all federal codes, or is there leeway for states to adjust those codes? Or is it because of 31,000, you use it, you comment of the OBGYN, 20 years the same? I mean, I don't know what stays the same for 20 years.
Sure.
But is it because they weren't loud? Did they not have a big enough lobbyist? I mean, what was it that happened that they did not get attention?
Mr. Chairman, that's a really good question. I don't know what happened, to be perfectly honest with you. Those obstetric rates, they were last increased when I was a senior in high school. So I have absolutely no idea what would have happened. My observation since I've worked for the state is there's a lot of turnover in leadership in my position in particular. Since 2017, I am the 4th Medicaid director. There's a lot of turnover in this position. That doesn't help because very often it's the Medicaid director who will lead some of these ad hoc requests. I think that contributes to it. You also have sometimes swinging back and forth between different administrations and what their priorities are. For instance, there were very, very few, if any, rate increases during CanCare 1.0. My understanding is a lot of that was coming from executive direction at that time. That was what the administration was seeking to do, control costs. So I think there's any number of reasons, but there just has not been any kind of formalized process to make sure that these rates are updated periodically. And so what we've been trying to do is make sure the legislature is kind of aware of what we're finding, because even within our agency, we don't have solid answers as to why things are the way they are. It's been a kind of a personal research project for mine to figure out how we got to here, and these are the best answers I have so far.
I appreciate your answer. Thank you so much. But that creates maybe a bigger problem as to when people choose to go into the medical profession, and you have to follow the codes, then you hear people saying, well, it's not fun anymore. Well, I mean, work doesn't always have to be fun, but it should be able to, you should be paid for what it is that you do. And if we're not reviewing these codes and getting away with it, I mean, that's absurd. I mean, when you think about it, because then how are they supposed to make a living?
I don't disagree with that assessment, Mr. Chairman, and I think that's what we've been hearing in Bethel recently from, I think that's what the pediatricians were saying, that they haven't received a rate increase. I can't remember, 96, I think that's when they said was the last time. So I think that's kind of a common refrain we hear, that, you know, you're not expecting to become a multimillionaire serving the Medicaid population, but you at least expect your costs to be covered for providing that service.
Thank you. Thank you, Mr. Chairman.
Representative Howerton.
Thank you, Mr. Chair. So is this the reason why it's people on Medicare or Medicaid are having issues finding doctors? Because I heard a lot of talk about that they're not taking new Medicaid patients, and that's their main reason why. It's not that there's less doctors, it's that they're...
Yep. Mr. Chairman, I don't want to speculate that that's the main reason why, but it certainly isn't helping because, you know, if someone agrees to be a Medicaid provider, there's no minimum number of new Medicaid patients that they must take. So what we hear sometimes is, I've been a Medicaid provider for X number of years, I'm now going to limit it to only 5 Medicaid patients a month, which then makes it harder if you're on Medicaid, if that's the only insurance you have, it makes it harder to get in to see the doctor. So it is kind of compounding those challenges, I do agree.
Representative Clifford.
Thank you, Mr. Chairman. So just going back to your premise about this needs to be at a sufficient rate to encourage enough, I'll say, physicians and providers to provide care. As you do this research, are you heading towards that number also? Have they been sufficient to get enough people seeing Medicaid patients? Thank you.
Mr. Chairman, to answer the question, my impression so far, just from my personal research, is that we have a large number of providers who are really, really dedicated to serving our population, and they've been doing it even in the face of stagnant rates. Even if they're not sufficient to cover their costs, they're doing it anyway because they believe in what they're doing. However, I think there's only so much time that we can ask our providers to essentially provide charity care for, right now we've got over 500,000 Medicaid members in Kansas. So that's a big ask to provide, at times, charity care for Medicaid members because our rates are low. My caveat to that, though, is that we didn't get here overnight. And I want to make very, very clear, if it wasn't already, that no one in this room is responsible for where we are now, and no one in prior administrations is either. This is the product of kind of decades of not a lot of structure and kind of loosey-goosey with the way rates have been increased. And I don't have any solutions or proposed solutions yet. Representative Carpenter alluded to what it would cost to bring codes up to Medicaid. I haven't asked our team to do that analysis yet. We've got 31,000 codes that they would need to review, so that's a big lift. But I would imagine that fiscal impact would be pretty sizable.
Just for my colleagues, I wanted to comment that the codes are owned by the AMA. The American Medical Association has the copyright on the codes, and then obviously different processes at the federal level apply values for Medicare. Many private payers go with those rates or lean towards those rates, and then obviously we have no system for Medicaid payments for those codes. Thank you, Chairman.
Any further questions? Well, you know what I'm going to ask. And so give us an idea of how this affects my question that I had dwelled on for a long time.
Mr. Chairman, would that be budget neutrality? Okay, I guess correctly. So, for the benefit of committee members who don't serve on the Bob Bethel Committee and maybe aren't super familiar with the structure of Medicaid, CanCare operates under what's known as a Section 1115 waiver. It's also known as a demonstration waiver. And it's a source of federal authority for us to be able to draw down federal dollars to help pay for Medicaid. Our current Section 1115 waiver is good for 5 years. It started at the beginning of 2019. It runs to the end of 2023. And so it lets us operate the Medicaid program in its current form and draw down federal funding to pay for it. But it does come with a couple of caveats. then one of those is that the federal government limits the number of federal dollars that we can draw down to help pay for the program. And they set that rate, they set that amount back in 2018, and it's good for the life of our 1115 waiver. So they set that rate back in 2018. Doesn't matter what happens, you know, global pandemic, doesn't matter what happens. We have to stay within those spending caps. And so, Representative Carpenter, we've talked a number of times about budget neutrality. And so, you know, we're limited on the amount of federal dollars we can spend per Medicaid member per month for CanCare. And so if we increase Medicaid provider rates, that increases the amount we're spending per member per month under CanCare. So we always have to have this in the back of our mind. Even if I could snap my fingers and bring all of our rates up to 65% of Medicare, we would probably blow past our budget neutrality caps, and that would be bad because every dollar we spend over those caps has to be paid for with 100% SGF. So the feds will step back at a certain point. Around this time last year, things were looking pretty bleak. We were very, very tight. We had very, very little wiggle room and a lot of work to do with Medicaid. I'm pleased to report, though, that based on what our actuaries shared with us back in December, we're in a better position than we were this time last year, that's for sure. And we think that we have enough cushion that if we were to do some kind of, you know, modest rate enhancements, kind of like what you'll see in the KDHE budget and the KDAD's budget coming up, and maybe a couple ad hoc requests from provider groups, I think we'll be fine. But we are continuing to monitor that very closely. We also have an outstanding request to CMS to raise our budget neutrality caps because we think they made an error in calculating them. So they haven't ruled on that request yet, but we're cautiously optimistic that they will agree and raise our caps even further. So I appreciate the question, Mr. Chairman. It's always important to ask when you talk about spending more Medicaid money, but we're in a much better position than we were a year ago.
Well, committee, I lost several nights' sleep last year when some of this committee's proposals and our budget neutrality was in danger, and because of spending. And I have, Director Fertig, I have made I've simplified budget neutrality down to something that I can understand. And so what I say is, if you serve more people with that money, it doesn't affect budget neutrality. But if you spend more money on the same people, then it affects budget neutrality. So that's very simple for me to understand, but it's a good way of looking at budget neutrality because it's 3 pages long to actually, you know, look at the actual formulas. So anyway, I've kind of come to that after all these years, but literally I was scared to death last year that we were going to go over our budget neutrality cap by the spending that we spent because we were spending that money on the same amount of people in our nursing homes and in our ID community. So it directly affected our budget neutrality, and we didn't have clarification from CMS that we had what we have now, which is how much is it now? Do you have a close amount?
So it's not a number that you can pin to the wall and just leave it there. It kind of fluctuates because every day we're spending money on Medicaid members, and every day they're either using more or less services, and so it kind of fluctuates. But the last estimation that our actuaries provided to us in December was that even if our year-over-year growth in spending per Medicaid beneficiary per month was in what they considered to be the high range, so around 4 to 5% increase year over year, we would still be set to come in at around, I think, $130 million under our budget neutrality cap. That's a pretty decent cushion, we think. I would like to increase it more because, like the chairman, I literally lost sleep over this last year on more than one night. And so, you know, for that reason, that's why we're pushing CMS to give us even more cushion. And I will be keeping the committees apprised if and when we get good news on that front.
Another question very quickly. Do caseloads affect budget neutrality?
Yes, Mr. Chairman, they do.
And what about the waiver?
Are the 1115 or
Oh, the
HCBS?
HCBS.
Sure. Yeah, all of the spending that we do for all 7 home and community-based services waivers, that all flows into budget neutrality as well. So as we spend more on those waivers, that also impacts our budget neutrality cushion.
Very good. Committee, further questions? Representative Vaughn.
Thank you, Mr. Chair. Just to follow up, how's the budget neutrality cap determined?
I'm sorry, how is it determined? It's okay.
How is the budget neutrality cap determined? Thank you.
Sure. Mr. Chairman, CMS sets the budget neutrality cap. There was some negotiation back and forth between the state and CMS back in 2018. I have talked to folks who were involved at the time. My understanding is that even Governor Collier got involved. There was the folks representing the state at the time really did everything they could to fight for us, but we had a very poor bargaining position, and CMS under that administration had a very tight view of how much money the state should be spending. And so their efforts to try and argue for the state were kind of futile. So we're kind of hoping that under the new CMS administrator, we might have a little bit more traction with our arguments.
Thank you. Thank you, Mr. Chair.
Representative Ballard.
Thank you, Mr. Chairman. But that doesn't mean that the budget neutrality cap is the same for every single state, though, does it?
No, Mr. Chairman, and that's a good question. So there are other states that have Section 1115 waivers. Tennessee has a really big one like us. In Kansas, 95% of our Medicaid population is under CanCare or the 1115 waiver, so it affects most of the Medicaid program. That's why we worry about it so much. Tennessee also has a very big one, but there are some states that have a very teeny tiny 1115 waiver for just, maybe 500 people for a pilot program. That's it. So they set it waiver by waiver, and it depends on how many people they're covering, what services they're providing. But yeah, Mr. Chairman, to answer the question, it is set state by state and waiver by waiver. There are some states that have more than one Section 1115 waiver for teeny pilot projects they're running. And it's set per 1115 waiver.
I'll ask you about the waivers too, because it may be United States, but we're not united in terms of our spending where we are, because neither can we determine each state has the same revenue. We are a low revenue producing state. There are bigger ones that have a large revenue. Some we don't even charge, income tax. So you can go through what it is, but is there anything uniform that's there that all states are governed by?
Oh boy, Mr. Chairman, that's a really good question. Other than the general laws in federal statute and regulation that we all have to comply with, and so much of what Medicaid does is very closely prescribed by federal laws. Other than that, no, not really. It sounds cliche, but you've seen one state Medicaid program, you've seen one state Medicaid program. They're all very, very, very different, and the types of services covered, the populations covered. There are some basic floors that the state cannot go below, and a couple caps, ceilings that we cannot go above, but in between that, there's a lot of variation from state to state. We all have to comply with federal law, obviously, whatever state laws apply to our programs, but those vary widely from state to state as well.
Thank you very much.
Committee, further questions? Very good. Thank you.
Thank you.
Committee, this will be an important part of our budget process, and that's why I made it such an issue, is because unfortunately it will be. As we look at these provider rates and all this kind of stuff, we have to keep in mind, budget neutrality and the long-term effects of that. So anyway, very good. Thank you again, Director Fertig. Okay, next I have Amy Penrod. Amy, you're up to talk to us about long-term services and support, ks. Thank you. Thanks for being here.
Good afternoon. Again, my name is Amy Penrod. I'm the Commissioner of Long-Term Services and Supports with KDADS. And my presentation to you today is a little bit on home and community-based services reimbursement, as well as some nursing facility reimbursement information for you. As Director Fertig covered a lot of the overall Medicaid, this is more specific to home and community-based services. All home and community-based services are funded with a mix of state and federal share, and that's calculated based on our federal Medicaid assistance percentage. And this FMAP is computed from a formula that takes into account the average per capita income for each state relative to the national average. And as you may know, the approximate blended FMAP rate for Kansas is approximately 60%, and that does not include the 10% enhanced FMAP that we are currently able to draw for the Section 9817 of the American Rescue Plan Act funding. Kansas Medicaid services are delivered through a managed care system. Managed care is designed to organize and manage the cost, utilization, and quality of services. Managed care provides for delivery of Medicaid benefits and additional services through contracted arrangements between the state Medicaid agencies and managed care organizations. So the MCOs accept a set per member per month capitation payment to provide Medicaid health benefits and additional services. And as you know, Kansas contracts with 3 MCOs currently to provide services through KanCare: Aetna Better Health of Kansas, Sunflower Health Plan, and United Healthcare. On slide 4, I wanted to be sure to give you some information, and a lot of this is going to be for your reference. You can peruse it later because there's quite a lot of numbers here. In managed care, the state sets the Medicaid floor rate for each covered service. So like Director Fertig was speaking about, we set that floor rate in managed care. The floor rate is the lowest rate the MCO is permitted to pay a provider per unit of service. So the tables on this slide and the following several slides are KanCare Medicaid floor rates from 2017 to present for home and community-based service waivers. And as you'll see, they're broken out by each waiver and then the services that are offered on that waiver. So slides 5 through 10 are all HCBS floor rates for the designated waivers for your reference. And then I think we can go ahead and skip forward to slide 11. And I wanted to make sure that you had some basic knowledge or basic understanding of some of the flexibilities that managed care affords us in the state. Because we utilize managed care, there are some additional flexibilities for provider payment models outside of the traditional fee-for-service. So like I said, all those waiver rates on those tables are the floor. So the MCOs can negotiate with providers to pay above that rate, either on a provider-by-provider basis or a case-by-case basis, a HCBS participant-by-participant basis, and those would be called single case agreements. They can do value-based payment agreements with a provider, so paying for certain outcomes or paying an enhanced rate to obtain certain outcomes. And then in lieu of services are another option, and that is an option where the MCO can pay a provider to provide a service that's actually not on the list of our HCBS waiver services, but if it is a cost-effective and quality and otherwise effective service for the individual, they can elect to pay for this service in lieu of the Medicaid service. And I wanted to take the opportunity, as Director Fertig mentioned, you will hear more about this when you hear KDAD's budget, but I did want to take the quick opportunity to review a couple of the KDAD's enhancement requests that have been included in the governor's budget recommendation that will impact rates provided to home and community-based service providers. So the first is, and Director Fertig mentioned this, mentioned both of these actually, the increase in specialized medical care rate for the IDD waiver. So the governor's budget recommendation includes an enhancement of $1.67 million to increase the specialized medical care rate for the IDD waiver, and that will bring the IDD waiver rate up to match the rate that was approved by the 2021 legislature for the technology-assisted waiver. We have found that kind of that parity issue was causing some problems among providers. Of course, it'd be more desirable to serve an individual that you can have a higher reimbursement rate for. So we want to be sure we bring that up and kind of equalize it. So that removes that bias. The second item that we have included in our budget and the governor's budget recommendation includes is an enhancement of $23.2 million, of which 9.25 is from the state general fund, to standardize some of our home and community-based service personal care service, or PCS rates, across the waivers that have that service, and then to provide a further 2% increase to that rate. So standardizing and increasing PCS rates will allow for, as Director Fertig also mentioned, she's got it down just like, just like we do, a more seamless transition between waivers. We have had a lot of issues with a particular waiver. For example, the BI waiver. The personal care service rate for the BI waiver is a little higher than the rate for the physical disability waiver. When a person's ready to transition off of the brain injury waiver and maybe onto that PD waiver, the rate for that personal care service would have to take a hit. That not only caused some reluctance to transition, because an individual would be nervous that they might lose their caregiver. Their caregiver may have to take a reduction in pay in order to stay with them. We want to be sure we bring those levels up to kind of a consistent rate. And then also, as we have heard over the last year or two plus, we have a significant workforce issue. And to assert that this particular enhancement request would solve that problem is not what I'm doing, but it does provide the potential for some increase in pay rates for our direct service workers that do a lot of that really hands-on work, the really hard work, a lot of responsibility, and we think that this is a very modest increase in request. And so I wanted to also give you some information on slide 13. That includes kind of the list of services by waiver that will be impacted by the proposed enhancement request. This gives the service, the procedure code, our current rate that we pay per unit, and then the proposed rate after the increase, and then it also gives you the percent of change. So as you can see from this, I think I need a magnifying glass for mine, but as you can see from this, some of them are increasing by 2%, while others that have been far below the other personal care service rates are going to be bumped up significantly. For example, on the IDD waiver, the personal care service rate would increase under this proposal by 21.87%. Sure. I think it's most of the way down the page here on the slide, the IDD waiver personal care service rates would be increasing under this proposal by 21.87%. And that's simply because their current per unit rate is $3.08, which is quite far below the other personal care service rates provided on the, for example, the BI waiver or the even the PD waiver or frail elderly waiver. So, yes. Right, right. On slide 14, I've started talking then about nursing facility reimbursement. And, you know, this is just a very brief overview of nursing facility reimbursement. The rate setting process, as was identified earlier, for nursing facilities is a little different than kind of the ad hoc process that we go through when we're identifying rates for, you know, fee for service. Each facility submits a cost report to the agency, to KDADS, and those cost reports are then used to set a rate for that individual facility. So the rates are specific to each facility based on that facility's reported costs. The rates are prospective, so they're set based on a 3-year period of reported costs and adjusted for inflation within the available appropriation. So those are kind of the key words within available appropriation. We do the best we can do with as far as adjusting for inflation, et cetera, based on the cap that we're given then from the legislature. For fiscal year 22, the rates include a 2017 to 2019 base period, so using cost reports from 17, 18, and 19, with inflation adjusted through March of 2020. And then facilities are paid a per diem rate. On slide 15, I have included a table that shows the nursing facility reimbursement information from 2009 through fiscal year 2022. The cost report for each facility is required each year. The cost reports are due at the end of February for the previous calendar year. 3 base years are used for the rate methodology, as I've said. And then there is a statutory requirement that requires the agency to use the 3 most current cost report years. And that is also then subject to appropriation. So that citation, I think, is 75-5958. And then based on this table, just to point out a little bit here, the years that appear in red represent when the agency was able to use the 3 most current cost report years, and that does align with statutory requirement. The years listed in black, we have had presumably, and I believe this is the case, a proviso in the appropriations bill that said that the agency doesn't have to. And that would be how we would not have used that rolling 3-year cost report average. I know that's really, really basic. And if you have questions, I'll be happy to take them. If I can't answer them, I will find someone who can and get you some answers. There's good reason why we have some experts that sit there and crunch the numbers for us.
Very good. Thank you. Good to know. Committee questions? Representative Ballard.
Thank you, Mr. Chairman. I'm sorry, I was listening, but I must have missed something. When you said those years in red, and I'm particularly looking at 17 through 20, what did you say about that again? Because I didn't quite get it. I'm sorry.
Sure. The years in red represent when the agency was able to comply with the statute. We did use the 3 years of cost reports, the 3 most recent years of cost reports to calculate the per diem rates for each facility.
And then, so therefore the black?
The black,
You couldn't.
we couldn't.
Is that good or bad?
I think that it bad.
I was trying to think of a better word, but I was trying to.
No, I mean, that would be less than ideal in, I mean, it's contrary to statute, but we did have legislative language that said notwithstanding,
So
you know,
does that mean
KSA.
that extenuating circumstances would have occurred, or something would have been anomaly, or I mean, what would have set that up?
Based on my experience and my, you know, my history with the agency, those were all related to budget issues, you know, not having enough funding, having shortfalls each year, you know, something's kind of got to give. That was one area where it was determined that maybe an increase didn't have to be provided. It all came down to the dollars and cents.
Okay, now that makes more sense. Thank you, I appreciate it. Thank you, Mr. Chairman.
Well, and governors, it's statutory required, but it doesn't have to happen. And some governors have not included that in their budget. And just a little background on this, there is some effort, I think, to maybe clean this up a little bit more. If you think about, just for instance, this last year, as an example, and we did provide a 3% rebasing, they call it reimbursement rate for nursing homes last year. But when you think about the process, we were doing 17, 18, and 19. And we were already through the budget process last year when we got the numbers, because the numbers come May or
April, May, late April.
Okay, so we're already through the budget process. So when you think about that, it's a 5-year delay. Well, a lot of times when inflation isn't that bad, it's maybe a little bit. But, you know, these last 2 years where we're talking about annual inflation of 7%, for instance. And keep in mind, this is actual cost. So it's what the nursing homes actually spend on commodities. It's actual measurement of their costs. And so I think there's some need for improvement, speed. You know, I mean, we're 5 years behind when we give them ideally from the worst year, 3 years from the second or the last year. But we get behind that way. And those folks are paying those bills, and we're supposed to, you know, make up for that. And so anyway, there's some talk out there about maybe doing something to correct that. Anyway, committee, further questions? Well, you got off further. Well, Benj, you got off so easy. Can you tell us a little bit about the 10% FMAP? And I've actually had, today I've had several questions about where that's at in the process. And I know from CanCare Oversight that it's a daunting process to get that money out there, but nevertheless, it is needed desperately. And I don't care if you have to handwrite those checks, you know, we need those out there among our providers.
Yes. I'd be happy to give you an update on some things that have occurred since I last talked with you maybe a couple weeks ago, where things are I'm trying to get things moving along faster, and I think that progress will move faster from here on out. We did, the last time we talked, the state had received kind of a notification that we would get our approval for our FMAP plan. We were told, okay, go ahead, but we hadn't yet received that formal approval letter. We received that yesterday. So that, I know that makes me feel a lot better. I know that makes our colleagues at KDHE feel better about, you know, really hitting the gas then on these, that we have that formal approval letter. We have identified, I've had to go through a little bit of a process to determine or identify a vendor that can help us organize. Yep. Oh. Sure, I'm sorry. That's okay. Yeah, so the amount of money that Kansas is expected to draw down based on that 10% enhanced FMAP is about 80.3 million. And the way that that works is that based on our expenditures for qualifying Medicaid services from April 1st of 2021 through March 31st of 2022, so that's our time period, we get to draw down an additional 10% in federal funds based on our qualifying expenditures. That will be approximately 80.3 million. And we feel pretty good about that estimate based on the first 3 quarters that have been calculated thus far. What then happens is that additional federal funds that we get is meant to, and the state is required to then spend that state general fund savings or the state fund savings that we would have spent on home and community-based services. We're required to reinvest that state money into home and community-based services to ensure that we are supplementing, not supplanting, home and community-based services, that we are enhancing services, building services, and really strengthening the system. So I certainly don't want there to be any confusion because this question has been posed to me before. We are drawing additional federal money, but the money that we are spending, that is state savings, then that we are required to reinvest into the program. So as you see us moving forward and reporting on expenses related to these projects, those will be coming from and will be tracked separately. They are state funds that will be spent. And we have a very meticulous process for tracking it all, because not only are we accountable to you, we are also accountable to CMS and a quarterly reporting process for them that looks to be pretty rigorous as we get going. So.
And they have a very vigorous program that they've been working on for quite some time as to how to disperse that money.
Yes.
And that is one-time money that will go out to, they've identified, it's a very complicated, we'll hear about it in KDA's budget.
Yes.
About the whole program and what you plan to do with that money. But
we've got workforce projects, we've got employment, and then we have access to care. And I think that all of those have been really identified as high priority needs for the system. And again, like the chair said, this is one-time money. So we've really focused on how can we invest that one-time money to strategically place ourselves in a good position should there be additional either federal support or additional state support that comes along that can, we can use this as our base and our springboard and kind of set us up for, to be in a good strategic place with it. The highest priority project is to get some funding out for our providers and our direct care workers, for our providers and HCBS employers to be able to provide recruitment and retention bonuses to their employees. And the amount of money out of that 80 million that we have set aside for that is approximately 50 million. So the largest chunk for that.
Very good. Committee questions. Representative Reeves.
Are we going to hear about this on Friday at the Bob Bethel?
Yes, I will be providing an update. I haven't included it. It's not in super great depth, but I had planned on giving some kind of a quick overview and then a status update on where I'm at with some of these projects.
Great. Thank you. Thank you, Mr. Chair.
Any further questions? Well, I think the one thing, and I'm not sure, and I'm sure it's very complicated, but how to disperse that money and how did the employer, I mean, all of it has to be tracked. So did they give it in bonuses one time? I mean, all that stuff, which is very complicated, and I hope you have figured it out.
We are getting very, like, I've got most of it kind of figured out now. I've got the help lined out. I've got methods for making the payments and tracking the payments. So I think some of the issues or kind of problem solving that we were doing initially, I think some of that's starting to smooth out, and we can really hit the gas and get going on this.
Any guess as to when the first check will go out?
I don't know exactly. I'm hoping that I will have a better estimate of that within the next couple weeks as I meet with the vendors and our payers, which will likely be the managed care organizations, because they already have a payment relationship with.
Yeah, very good.
Yep.
Okay, committee, further questions? All right, thank you very much for that. I'm sorry I pressed you into some more service with that, but it was just ironic that I had several phone calls and people caught me and said, hey, you know, when's that money coming out? And I thought, I need to know that too. So anyway, very good. All right, thank you. Committee, tomorrow we will hear, we don't have, oh, we're closed tomorrow? Well, good thing I'm not the boss. We'd be working. Okay, well, very good, committee. I guess we'll be adjourned until Thursday. Yes, would you please? Yes, yes. So, oh, it does. If we can, we will be. I mean, no. Yeah, I was going to say, don't worry about it. We're just going to start, just like we did yesterday. My days have already run together, but we'll have a hearing and presentations from I think it's Veterans Affairs, the Board of Nursing, and Healthcare Stabilization Fund. Yeah. No, we'll probably do it on Thursday. Yeah. Well, we won't do recommendations on the same day. No. We'll just have the hearing, and then we'll have recommendations probably Monday. Are you okay with that? Oh, that's true. That's true. Okay. Yeah, that's next Monday. So, well, stay tuned, committee. We'll have to. Right, but so stay tuned, committee. We'll keep you informed about what we'll be doing when we move this out farther. Okay, very good. We're adjourned.